All right, so we might get started. So just wanted to start first of all with an acknowledgement of country. So I'd like to acknowledge the traditional custodians of the Macquarie University land, the Wallumattagal clan of the Darug Nation, whose cultures and customs have nurtured and continue to nurture this land since the dream time. We pay our respects to elders past, present and future. Well, I'd like to say welcome to our 13th year of our Mental Health Month annual public lecture. I want to particularly thank those of you who I think have attended all 13 of the lectures that we have been running, and I'm pleased that you are not sick of hearing from me. But luckily this time you won't be hearing too much from me. We've got three fantastic speakers actually lined up. I'm very excited because this year we're going to have speakers that will talk about mental health across the lifespan. So from children through our adult years into our older adult years as well. And we're also very excited because we're going to share with you a special documentary that was made from one of the participants who was going through a program here at Macquarie University. And she tells her story of anxiety and depression and her recovery. I'll tell you a little bit more about it a bit closer to the time, but I think it's a very special little film that we want to share with you. So just before I introduce the speakers, I wanted to tell you about this lovely slide and that you can see here. So this is actually the image for our new research centre that we have here at Macquarie University. It's the Lifespan Health and Wellbeing Research Centre. And so it brings together the Centre for Emotional Health and the Centre for Ageing, Cognition and Wellbeing, along with colleagues across law, education, medicine, health economics, business, linguistics, cognitive science and psychology. So it is now a bit of a large centre, but we really hope that this multidisciplinary focus will help us to tackle big problems in new ways. So our three speakers today, two of those are actually co-directors of this new, co-deputy directors of this new centre. So that is Associate Professor Carly Jonko and Dr. Lauren McClellan. And the third speaker is the director of the former Centre for Emotional Health. So we're very lucky to have a great lineup here today. All right, so without further ado from me, I'm going to introduce our first speaker for the evening. That's Dr. Lauren McClellan. Now, she's going to tell us about a very exciting project for which our team recently won a successful $10.5 million tender, which will actually enable us to develop and deliver a national voluntary mental health and wellbeing check-in for all Australian school students. So over to Lauren to tell us about this very exciting project. Thank you.
Thank you. Thanks, everyone. Thanks, Viv. Yes, I'm really pleased that you've come to our beautiful Wallumattagal campus, and I'm really excited to talk to you. Oh, sure. Is that a bit better? Okay. Yeah, really excited to talk to you about this new project. I'm going to have to lean forward.
That's what you get for being too tall. Yeah.
Shall I take my shoes off? Okay, so... Oh, that's okay. No, it's fine. That's all right. Thanks. Just remind me, wave at me if I move away from the speaker. All right. So I firstly wanted to acknowledge the huge number of people who have contributed to the research. The foundation of this government tender has been drawn from really significant and exciting research. And so there's a huge group of people and organisations who've been involved in that project. And then, of course, also acknowledging the extra contributions of some additional wonderful staff at Macquarie and the government funding that supported this new tender. So some background. The question is mental health an issue for youth? And of course, I think we all know that the answer is yes. We know that poor mental health is common in youth. About 14% of youth experience mental health problems. Sorry, 14% of youth experience mental health problems. And it is one of many common mental health problems occur in childhood. So it's some of the problems that occur early in this our development as we age. it also often leads to cumulative difficulties. So when a child or young person experiences a mental health problem when they're young, it continues to build and accumulate more and more complex and long-standing difficulties. Sadly, a lot of young people are with these diagnosed difficulties don't actually get the appropriate help, even though we know that there are really good treatments that people can access. And so they slip through the cracks. They suffer and they experience difficulties and impacts in their life without being able to get support. So not only does that impact their peer relationships, not only does it impact their families functioning, because often these mental health problems have large impacts in a range of different areas of functioning, but it also impacts on their academic attainment, impacts their attendance at school and how well they're able to learn across multiple domains. And so some of our Australian surveys indicate that there is about 2 years lag in academic performance for a young person with a diagnosed mental health condition compared to a peer that doesn't have those difficulties. So this tells us that it's also having a really significant impact on their education. So I guess the question we posed ourselves was, how can we find young people with mental health disorders or mental health problems earlier and make sure that we can get them to services as quickly as possible? So one of the answers to that question, and one of the options that's been contended with in the research, is to actually do universal mental health check-ins in schools. That means that regardless of someone's experiences, you would assess all the students in a school, and then with that information, have some indicators of the students that might be struggling or experiencing difficulties. The problem with this idea is that the research is not very strong. And so what we have found in the very limited number of studies that have been done is that most of the questions that are used in these kinds of systems are not actually developed for universal school testing. There is very little scientific evaluation available. They typically focus on one problem, even though we know that young people will potentially experience a range of different problems like behavioural difficulties or anxiety or depression. And none of the measures that have been tested include impacts on functioning. They only talk about symptoms or problems. And nearly all of the measures that have been researched require payment. And so there's a really significant cost associated with doing this on scale. So Ron Rapay, one of the professors in our centre, has been doing a lot of research, and a number of us have been doing a lot of research on school-based mental health. And some of the work that he's been leading over the last few years has really focused in on this problem. So in 2017, we were actually approached by a group of schools who said, we've got this really significant problem. We can see the mental health impacts amongst students in our schools, and we don't know how to help them. Can you help us? And so as part of that process, there was a package of work that was begun to work with these schools to develop some purpose-built and scientifically evaluated questions to help schools identify students that were struggling. Part of that work in 2020 involved actually trying to understand what was the appetite in school communities like for this universal screening. And so there was a survey conducted amongst school psychologists across Australia to try and look at the attitudes and barriers to mental health check-ins. And what that showed us was that lack of knowledge about how to do this, the costs associated, and concerns around reluctance amongst community members to actually do mental health checking in schools were some of the biggest barriers that school counsellors identified. And then luckily in the back half of 2020 and into 2022, funding was received from Bupa Foundation to help us do some research to actually address this problem and do some really good research. So what did we do? So we tested 70 schools. That's about 14,000 students from grades 4 to 11 across all school sectors, so government, non-government, independent schools. And there was really good representation across the schools that we involved in our research. from low socioeconomic status, including a whole range of different regions across New South Wales, and also importantly, cultural and linguistic diversity, which did also include students identifying as Aboriginal and Torres Strait Islander. From that cohort, we developed a range of different tools. So we have now a purpose-built mental health check-in tool called the Beacon, which focuses on anxiety, concentration problems, mood difficulties, and eating concerns. And there was also a package of work done around wellbeing and measurement in schools that focused on things like school belonging, peer acceptance, family connections, and peer victimisation, just to name a few. And importantly, as part of this process, we developed really clear, useful guidelines for schools that would help them to plan for checking in on their students, actually conducting the check-in, and then, of course, really importantly, what do you do with that information, and giving some structure and support to schools to action. And then, I guess, to add the science on another level, we also did some comparisons. So we split those 70 schools into two groups. In fact, it actually came down to about 64 schools. So we split them in half. We did the check-in process and provided the guidelines to half the schools in 2021. And then in 2022, we provided the other half of the schools with that information. And we compared how the schools went amongst those who got it initially and those who didn't. So what we found was around about 12% of the students in these schools were reporting levels that were considered to be struggling. And when we tested, excuse me, I'm just getting a warning to say this is going to shut down in 10 minutes. So do we need to scan something? Or?
You keep talking.
Thank you, Viv.
I'll press buttons.
Thank you. Thanks, that's gone now. So, so we found that was stable in the two cohorts. So even with a year passing, it was around about the same proportion of kids struggling. So that didn't seem to change anything amongst the two separate groups of schools. But really interestingly, what we found was when we assessed the students a second time who had originally been given the check-in tool and the guidelines, we found that there was actually a drop in the proportion of students struggling with their mental health that second year. So that tells us that something was changing for these students, where their school had now got information about the mental health difficulties that they had experienced and changed in a positive way. The other thing that actually quite surprised us was we found that the number of students that were having absences from school was actually significantly fewer school absences in the group that had, in that first year, received the support, the identification and support for their mental health. So not only was it reducing the percentage of students with mental health difficulties, but it also seemed to create a difference in the impact on attendance amongst those schools, which are two really important outcomes for this idea of universal mental health checking in schools. We also surveyed parents and asked about their attitudes to their children doing mental health check-ins in the school environment. And I won't go through all those statistics, but just to point out that they were really positive. Around about 87% of parents said that they thought it was important for schools to carry out these kinds of processes. And only about 8% of them thought that there was a chance it could be harmful. Now that's still 8%, but it's a very, very small number out of 100. Really excitingly, the students also had really positive views about mental health checking in the classroom. Nearly 90% said that the questions didn't make them upset at all. And around 80% of students said they thought that it was important for schools to do this. So this speaks to those barriers that we identified in that first round amongst school psychologists. It is actually a lot more positive amongst parents and students in those schools that had actually done this process with us. So off the back of these great results, we submitted to the Australian Department of Education to roll out this process across the country. And we were very pleased to be selected to lead this national rollout. And so this is part of the package of work around helping kids bounce back from COVID. really highlighting the importance of mental health in the education space. So this tool will now be used across the country as of term 1 next year. And the objective is to help schools to gain an understanding of their students' mental health and wellbeing at a particular point in time, so that schools can use this information to make decisions to support their students. So it's really to give schools additional information to support their students. It will be available to all Australian schools, regardless of sector and regardless of grade. It will be free for schools to use, funded by the Federal Department of Education. It will not only assess mental health, but also importantly, give schools information about some potential protective factors and more broadly, a student's wellbeing, and that will be evidence-based. It will give students a voice because it's from their perspective. Students will complete the check-in under supervision of a teacher in the school. And while it is important that it's a student's voice, it's also really important that we're clear that this is not necessarily diagnostic in nature. It's just to give schools extra information about mental health and wellbeing. It will give schools both individual information about a particular student as well as information about cohorts, so a whole grade or a whole school, and how they're tracking over time with mental health and wellbeing concepts. And it will be a process where we've partnered with schools and their communities all the way through, so that we can together try and make this service as beneficial as possible. So if you want to find out more, you can scan this QR code. There are also flyers on the tables out the front. It's really great to start to share this information with the community so that you can hear about what's coming and potentially also get involved in helping us shape this tool. If you've got school-aged children that you know, if you work in education or in mental health in the school setting, I'd be really keen to hear from you. Thank you.
Actually very excited to say our last speaker is going to talk to us about mental health in later life. And so I'm going to introduce Associate Professor Carly Jonko, who's going to tell us about some 10-year outcomes where she has followed up some of the people who went through our programs, some of our earlier versions of the program when we ran Aging Wisely as a group therapy program. And she's going to tell you how those people fare in 10 years later. So if any of you are in the audience, thank you for completing Carly's questionnaires, because we can now tell you what those results are. So Carly.
Hello, everyone. You can't ask for a better introduction to that. This really is a glass is more than half full story. Sorry, I'm too tall for these small lecterns. Is that better?
Yes.
Yeah, wonderful. This is really a glass is more than half full story. So we'll turn that around. And there's so many really wonderful themes that came up in that video. So thank you, Helen, for doing most of my introduction and really setting the scene for a positive outcome. This is going to be quite a research talk, but I think it's very accessible. I'd just like to acknowledge the collaborators that I have on this project. Some of these people were involved in the original trial, and some have been working with us on this trial, this more recent trial, as well as the research team who have done all the hard work actually pulling all of our data together. So just a little bit of background. So we know that anxiety and depression will affect around 1 in 10 older Australians. And it's associated with a range of really negative outcomes. It's associated with poorer quality of life, with less life satisfaction, increased rates of loneliness. It can have quite a profound impact on people's physical health and their management of physical health conditions, increase their functional impairment and their disability. It also has impacts on them, on society, and also the trajectory moving forward. So it can impact people's employment, both paid employment, but also their roles as in unpaid volunteer roles or carers for grandparents and other people. Looking forward, it can actually increase people's risk for dementia and increase their risk for suicide. And it also increases the amount of times that people tend to utilise the healthcare system. So it increases societal costs. So mental health in older people is not a normal part of growing older, and it is associated with a range of negative outcomes. And yet very few people will seek treatment. So older adults have one of the lowest rates of help seeking. So we know that less than 1 in 3 people who are experiencing a mental health problem will actually receive treatment. And even fewer among them will receive evidence-based treatment. Primarily, people are receiving medication. There's very few older people who are being referred for psychological care. So hopefully at the end of this talk, if you're not already convinced by that wonderful story there, you will start to see that psychological care really is an effective and useful option for older people. So we've known for a long time, and a lot of the research that some of you might have been involved in and might have heard about in our previous years of lectures have shown us that CBT or cognitive behavioural therapy is effective for older people who experience anxiety, for older people who experience depression, as well as older people who experience both anxiety and depression. And we know that people who experience both anxiety and depression actually tend to be more severe. They tend to have a more chronic course of their illness, and they tend to have poorer treatment outcomes. So they're a particularly tricky group to treat. When we are looking at improvements among older people, I thought this would be a helpful graph just to illustrate what I'm talking about. We often see people who experience some kind of mental health problem. Maybe I'm going to use a pointer here. As we go through treatment, we hopefully start to see a treatment response. So people's symptoms starting to improve a little bit. And the goal of our treatments really is symptom remission. We want those symptoms to be gone at the end of our treatments. What the research shows us is that somewhere between 40 to 70% of people will show short-term remission. So at the end of treatment or within these very short follow-up periods, they will no longer have an anxiety or a depressive disorder. But very few studies will look at what happens after this short-term outcome. And the real concern is, what if that doesn't last? What if over time their symptoms come back and they experience this relapse over time? So majority of the research in older adults so far has really only followed people between 3 months to about a year after the treatment. And again, we tend to see pretty good outcomes, but we don't know what happens after that. There can be lots of additional challenging events that will pop up over time, particularly as you get older. So do these people stay well, or do those treatment effects start to wear off over time? Very few studies. In fact, I don't think there are any studies in older adults specifically that look at that relapse over time. So we've been doing trials here for many years, and we were interested to know, what about the long-term outcomes for older people? Do our treatment effects last? And how many people are likely to be experiencing this return of symptoms over time? So that's what we set out to ask. Do these benefits of cognitive behavioural therapy last in the long term? Is it better than other types of treatment? Is there something special about CBT, or is this just any kind of treatment might show a positive outcome? And also, how common is this relapse of symptoms? How many people experience their anxiety and depression coming back? We were in a great position because a long time ago, Viv led a trial looking at the outcomes of cognitive behavioural therapy for older adults who experienced both an anxiety disorder and a depressive disorder. So these are the harder to treat individuals who are typically showing poorer outcomes over time. So in this trial, there was 133 individuals who came into the trial who had both an anxiety and a depressive disorder. And they were randomly allocated, so they like pulling an option out of a hat to either receive the cognitive behavioural therapy package, so Aging Wisely. At that time, we were running this as a group program. We had people come into our clinic just across the hall here. And the types of treatment components in there are pretty standard for a CBT type of treatment package. Individuals learn a range of strategies to manage unhelpful ways of thinking and also ways of changing their behaviour. We also deal with things like assertiveness and dealing with grief and bereavement, which are often real challenges for older people. The other option is that they would receive a group discussion group treatment. So this group, they met for the same amount of time. So everyone received 11 two-hour treatment sessions. But this group was really focused around peer support, around socialisation, and around mental stimulation. So for half of the session, they would review their symptoms and their experiences. And the other half of the session, they would talk about mentally stimulating topics. Current affairs, things that have gone in your life, changes in technology, a range of different activities. And what we found in that early trial is that it had really good results. So you'll see here, these are two different ways that we tend to look at outcomes from trials, and I'll tell you a bit about the distinction. This is looking at the primary diagnosis. This is the most severe, the most interfering problem that people came in with. And this is a much, much, much harder bar to meet. This is looking at all of their mental health problems, all of their anxiety disorders, all of their depressive disorders. And what we are looking at here is also a really high bar. This is remission. This is people who are no longer meeting criteria for having an anxiety or a depressive diagnosis. And what we see on both of these outcomes is that at the end of treatment, people in the cognitive behavioural therapy group are doing better than the discussion group. But by 6 months after treatment, there's actually no difference anymore. This is not a statistically significant difference. The discussion group worked. It's actually a very effective treatment. This is actually an ideal situation for us to be able to follow up the long-term effects of treatment, because we have another treatment that was really effective. And very few trials are able to follow up people who received one effective treatment compared to people who didn't receive that treatment over time. Ethically, we usually give everyone the target treatment at some point. So this was actually a really great opportunity to follow these people up. So it's been about 10 years since people came through that treatment trial. We went through and we tried to get back in touch with everyone we could. So a number of people, unfortunately, had passed away. And we really were following up the people who had received at least half of the treatment. We wanted to know of the people who got the treatment, how many people maintained or lost the benefits of that treatment. So we actually managed to get about 60% of the original sample, which is a really good response rate for a trial like this, particularly when they hadn't heard from us in 10 years. So the people in our trial this time were aged between 70 to 84, and we had a mix of men and women. And we followed them up 10 years after they completed their original treatment. And we did a diagnostic interview with them over the phone. So if any of you are in the trial, if any of you were part of that trial, thank you for chatting with us again and doing that telephone interview again. What we found is, amazingly, that 10 years after receiving the treatment, the people who had received cognitive behavioural therapy had higher rates of remission of all of their diagnoses. So these are people who had no mental health problems at 10 years. So you can see here, this blue bar is the CBT group and the orange bar is the discussion group. You can see here that improvement from at the end of treatment to the 6-month follow-up, that was maintained 10 years later, which is a really high bar. The discussion group, again, you can see from the end of treatment to that 6-month follow-up, there was some improvement, but that didn't seem to last over time. And this was quite a big difference in being symptom-free, no anxiety, no depressive diagnoses at all. We also saw much lower rates of chronic treatment resistance. These are people who didn't lose their anxiety or depressive diagnoses at the end of treatment, and still were maintaining a mental health disorder 10 years later. So about 1 in 5, 21% of the people in that cognitive behavioural therapy group were still experiencing symptoms versus almost 60% in that discussion group. We looked at, could we identify who was more likely to continue to be in remission or to be in remission 10 years later? And really the only thing that we found was that if we treated them really well at the time, if we got them symptom-free by the end of treatment, they were 7 times more likely to be symptom-free 10 years later. So that was a really important thing to show that treating those disorders until they were gone at the end of treatment was an important predictor. We saw the same thing if we split apart remission of all of the depressive disorders and all of the anxiety disorders. So remember, everyone had both of these at the beginning. You'll see at 10 years follow-up, almost 90% of people following after that CBT group no longer had a depressive diagnosis, compared to almost half still in that discussion group. And we see similar findings for all anxiety disorders, that 63% of people in the CBT group had no anxiety disorders 10 years later, compared to 35%. In terms of how many people had a disorder come back, so when we successfully treated them, we looked at only the people who we had successfully treated to no longer have an anxiety or a depressive diagnosis at the end of treatment. And we wanted to know, among those people, how many experienced a return of their symptoms over time. And you can see here that, again, we see much lower rates of relapse. So up to 80% of people in the discussion group who we got symptom-free at the end of treatment experienced a return of their symptoms, in comparison to about 1/3 in the CBT group. We weren't able to predict who was going to relapse, though, unfortunately. This is kind of the summary slide that is really, I think, helpful for clinicians and for older people. So as we heard Helen talking about, there's this very pervasive belief amongst older people. Unfortunately, it's often by older people themselves, it's by their friends and family, and it's also by health professionals, which is particularly unhelpful, that psychological treatment might not work for older people. Perhaps they've had long-standing mental health problems and they might be too difficult to treat. And I think this is really exciting data for us to be sharing, to say that's just not the case. We can treat them in the short term, and those benefits last for up to 10 years later. They've got really, really long-standing benefits. So I hope this will be really exciting data to start challenging these beliefs that psychological treatment doesn't work for older people. It's associated with lower rates of symptoms, greater remission over time, much lower rates of relapse, and much lower treatment resistance compared to an effective treatment. So this isn't compared to receiving nothing. This is compared to receiving a good, effective treatment. So it's a really tall bar. So we've been really excited about these results, and I'm very excited to share them with you. So I'm really happy to take some questions, and we've also got some of our social media accounts down the bottom. So again, we've had some name changes with our new research centre, so I'd really encourage all of you who are on social media to come and follow all of our accounts, and you can see some of these updates from our research as they start coming out. So thank you.